if we view the comprehensive exam as an event rather than a process or an entry point to a process of care, then we will always have the weirdness that occurs and the discomfort that occurs that people will get caught up in. But if we can actually structure our approach, which is what we're trained to do, like if you look at all of look at the schools and we look at we look at ARBO and we look at all of our NBEO, like we're trained, we always advocate that we are the primary care providers for the eye and visual system. And sometimes our behaviors, and again, I think it's all based of good. I think that we do these things because we're just trying to care for the patient, but we build these systems in place that just don't allow us to fully do it. Well, hello and welcome back to Compliance Corner. I'm Dr. Chris Wolf with my good friend and partner, Dr. John Rompakis. And within Practice Performance Partners, what we're trying to do within Compliance Corner is we're trying to help you understand the things that are making us risky for audits and audit failures, and then trying to help you find ways to say, listen, I can be in compliance, but primarily I get to take care of the patient if I build systems around understanding those compliance issues in my practice so that I get to deliver the care that I want to deliver to the patient and really that the patient deserves. So Dr. Rompakis, thanks for coming on again. This has been fun. I'm really excited to do this one this week because there's a lot of uncertainty and opinion about this specific topic. And that's why I wanted to talk about it with you. Thanks for doing this.
You bet. I appreciate it, Dr. Wolf. We're going to have a lot of fun. I enjoy this topic, and it has been a topic of concern, since 2008 when the diabetic benefit first came into play. So let's dive into it.
Yeah. So what we're going to talk about today is we're going to talk about the diabetic eye exam. And, what I find, John, is a lot of times people talk past each other on this. They'll hear something from the stage or from, a blog or a social media, account. And they'll hear something like, this is what I always do, and this is how I get paid. And so I have a lot of fundamental issues with a lot of those things, not necessarily because they're wrong, but they lack contextual clarity. So let's start with giving us a history, John, of the diabetic eye exam as it relates to Medicare.
Okay. So 2008, it was a transformative moment in Medicare's history. So Medicare has been around since 1966. And as most people know, one of the major issues with Medicare is that Medicare had never paid for preventive care in any way. Something had to be broken before the doctor could diagnose and fix it and have Medicare be a responsible party in the transaction. In 2008, Medicare changed its policy, and a comprehensive eye exam for an individual with diabetes in the absence of diabetic retinopathy actually became the very first preventive benefit that Medicare ever put into place. It has some specific requirements associated with it. It had to be a comprehensive ophthalmological evaluation, so what we know is a 920X4, right? A new patient or an established patient. And it had to also include dilation as a specific component of that. So when we have taken this and now labeled it a diabetic eye exam, I think that it misconstrues exactly, we've kind of invented a name for a code that's already existed that has a, specific definition.
And actually, John, can I interject a little bit, because this is what's interesting and where it's kind of confusing, even for me, is you have a 920X4 and the CPT definition, the AMA's definition of a 920X4 includes dilation, as you and I know, if indicated, right? But
Correct.
CMS then is saying, no, it is indicated if you're going to use it with E11.9. Is that what you're saying?
That's exactly what I'm saying. So in the specific condition of doing a preventive service and billing it to Medicare, it became no longer as indicated, it became a mandatory component in order for Medicare's coverage to be invoked,
So interesting.
to do that. I think,
Okay.
Chris, just to relate back to something you said at the very start, wherever people are getting their information from, somebody on the podium, a blog, another online source, whatever it may be, I think that the thing that disturbs me the most is where most of the confusion about how to properly assign a responsible party and how you're supposed to carry out the execution of this examination is often driven by reimbursement, and it's not actually
Correct.
driven by the patient care component. And I
That's
think
right.
that's where I get so frustrated, because if we follow the pillars of how to establish this in your clinical practice, like you do so well in comprehensive optometry simplified, it's one of those things that you get to provide the full scope of care. You're not leaving anything out. In fact, you're enhancing the care over the course of that annual time period. It's just that people are looking at that single annual event of the quote unquote diabetic eye exam, and that's where they really get hung up. And I think that they're missing
No,
the
it's totally right.
foundational elements
It's totally right.
that's going to.
Yeah. No, sorry. Keep going. Keep going.
No, I was just going to say, I think that that's where, those are where the fundamental base elements of the examination are established that allows you to do the full scope care for concomitant conditions and things like that. And I think that people are trying to just load everything into one bucket, not really thinking about the overall longitudinal approach with this patient.
The kind of the thought, the internal thing as an optometrist, right? The optometrist in me, the internal thought that occurs, I think that's going through many of our brains is, well, if I just convert the patient to medical, which is, I'll tell you, is a term that I hate this term, and I hear it all the time, but I don't hate it because I hate the people that use it. I hate it because internally I feel the same thing, that if I convert a patient to medical, then somehow I alleviate this pain point of, I don't like the idea of a lower reimbursement for the opportunity to sell a higher ticket item to offset that reimbursement, that I feel like if I was able to convert them to medical, then I don't have that same tie, and I am justified, or I am worth the value more. But the problem is that just simple conversion, first of all, doesn't actually take care of the problem. This is a side conversation. I've gone a little bit down a rabbit hole, but it doesn't actually take care of the fundamental issue of generating enough revenue for the amount of time that most of us will spend with patients. So that's more of a conversation that, you and Peter are expert at in figuring out, like, how do we figure out our time better, our better use of our time. But for most optometric practices, it doesn't solve the problem. So herein lies this idea that from the podium, people are trying to do, they're just saying, like, listen, I just want to take care of the patient, but I've created this weird system that is not compliant in my practice, that I'm going to defend in front of an audience that just perpetuates the weirdness. And so now we apply the kind of the CMS, and I don't want to go too far. I mean, I can go way deep in the other realm, but I think that's what they're trying to do. I think they're saying, like, I just want to take care of the patient, but I'm so adhered to the cognitive bias of the annual comprehensive exam that I don't want to see them more than one time if they have these other concomitant issues, or I have to go deeper in those other issues, but I'll feel better about it if I can just convert them to medical and see them one time a year. But then it puts me out of compliance, because if that patient has a benefit someplace else, then what?
Yeah, I mean, here's the thing I wrestle with, right, all the time. Do you have a hypertensive eye exam? Do you have a hypercholesteremic eye exam? Do you have a Crohn's eye exam? Those are all systemic diseases that may not have any ocular manifestations, right? Just the same as E11.9, type 2 diabetes, without complications. So what the purpose behind this whole thing was, CMS understood that diabetes was becoming an epidemic in the United States. And so what they did, as far as the financial math is concerned, they understand that early detection of diabetes or diabetic retinopathy was probably the best thing that they could possibly do to intervene early and prevent vision loss from occurring, because once that happens, the cost to Medicare over the lifetime of that patient from date of diagnosis, age 65 through, an expanding lifespan of late 80s in males and females, they understood that cost was significantly greater. So they said, let's pay for an eye exam for a diabetic, even if they don't have diabetic retinopathy, because they would have covered that already with the 99,000 code.
Correct.
So they're saying we want a comprehensive evaluation, a 920X4, a dilated retinal examination, so that way the physician can do a detailed examination of the structure that was going to suffer the most, right, with a diabetic change, in the perspective of we can prevent greater side effects from happening going down, or sequela happening down the road, if we get early detection and intervention. And I think that what people are doing is they're mad at themselves because they've got to do a dilated examination, and they're spending whatever time they are, and they've agreed to a reimbursement for whatever carrier they're doing, and they want to try to upshift it to medical. So the very fact that the patient has diabetes does not mean that it's a medical evaluation, right? It's still a 920X4 at its core, with the specific instruction that it must include a dilated fundus examination. So my interpretation of that, and it's been this way since 2008, when there was a lot of questions because of its introduction, the authoritative sources basically said, look, a 920X4 is a 920X4 is a 920X4. So the very fact is if a patient comes in and if they have duplicative benefits, right, if they have option A and option B, it's the patient's choice of which benefit they want to apply to that comprehensive eye exam that's being performed. Because I will tell you, if I look on paper and I look at the two different eye examinations, and if they're exactly the same, right, whether it's a diabetic or not, because in today's world, I can tell you just from auditing charts, most people are not maintaining the dilation requirement. They're using ultra wide field or something in lieu of that. And so they're falling short anyways. If I was to get audited by the medical carrier and I didn't do the dilated component, they'd fail anyways. So, but it's the patient's decision on which benefit they want to invoke. And once they do that, now, again, because and I know diabetics they don't just solely have diabetes, right? There are concomitant conditions that go along. And if we really talk about establishing diabetes as a pillar within your practice, as you do in Comprehensive Optometry Simplified, it's one of those things that people can understand. This is just part of the sequelae that you deal with. This is the cadence of the examinations that you do. You're going to have an annual exam. A comprehensive exam is going to be performed, and you're going to be billing it to a party, whichever one the patient determines is appropriate. You're going to identify any other risk factors are coming into place, and you're going to set up a cadence of follow-up examinations during the course of the year that are going to strictly be going to medical, right? No question about that. They're going to be billed using an E&M code at the appropriate level. Ordered testing is going to be performed as determined by the patient's medical necessity, and you're providing this longitudinal care to the patient, right? They don't have diabetic retinopathy yet. They may develop it, but at least with that cadence, you are going to be part of the team that participates in the early intervention of that disease state and hopefully be able to prevent any significant vision loss from happening. And that's where we're really looking at this from, right? It's a global macroeconomic problem for the U.S. healthcare system, but the granularity is coming down to how do we work with that at the practice level and really make it all about the patient and the patient's longitudinal care as we're providing it.
Stop feeling overwhelmed and start running a safer, more profitable practice. Here's the next step. First, book a strategy call with us, Practice Performance Partners. We'll uncover the biggest risks and opportunities in your practice. Then, choose the package that fits your goals. From there, we'll get you launched with confidence, with clear systems, with expert support, and with peace of mind, knowing your practice is protected and set up to grow. Don't wait until something goes wrong. Book your strategy call with us, Practice Performance Partners, today. Yeah, and I think you made a point that I want to dig into a little bit, and I think this is the uncomfortable part for a lot of people is this patient comes in and assuming that truly all they have is, which again, I would push back, you would push back, that if I'm doing my job, the likelihood that a patient just has E11.9 and no other reason for deeper dives at some other point in the longitudinal care of that patient over the course of the year, and that's all that they're there for, then I get to do a comprehensive exam and that's it. Now, I would push back and say prevalence data does not support that a patient in that age group is only going to be there for that one thing if I've done my job right. But if they're in that, say, 3% of the population that has diabetes and nothing else, right? If they have diabetes and they have nothing else going on at age 50 or 60 or whatever, then we have E11.9. But what you're saying and what people are uncomfortable with is, let's say that that patient now you say has dual coverage, they get to pick which insurance they want you to use. That's where people get uncomfortable. They say, no, I get to pick because I'm saying that this patient has a medical condition. And I even go one step further when I talk to audiences all the time, is I try to put a very clear point on this. And I ask them, okay, well, let's say they have some managed vision care plan and they have another plan, but they don't give you any information on it. And maybe they don't even have another plan. And that patient comes in and says, I have diabetes. I need an eye exam for my diabetes. I have a plan here that pays for a 920X4 and a refraction. This is what I have. It's a managed vision care plan. You're not a provider on my other plan, or I don't even have medical. That's it. That's all I got. What's the optometrist going to do? Because we're afraid of asking the patient for money. Most of us, the vast majority of us, will take that managed vision care plan and build a managed vision care plan, won't we?
I think that, Chris, the supposition is that most optometrists assume, because they don't want to have this conversation with the patient, they assume that the patient is going to choose the managed vision care plan. That's what they assume. And so therefore, they want to take the choice away from the patient so that outcome will never happen. And when you actually dig into it, if the patient has duplicative coverage, you have to explain to the patient, look at Mrs. Smith, you've got VSP or IMED or whatever it is, right? You have a $25 copay or $30 copay for your examination. And for that, we will perform your comprehensive eye exam and a refraction. You also have Blue Cross Blue Shield that will cover your 920X4 with a zero copay, because Blue Cross Blue Shield has made diabetes a preference. Now, the refraction, we charge XYZ out of pocket. So I can bill Blue Cross Blue Shield. It'll cost you nothing, and you'll have to pay for your refraction, which we can determine, whether you need a change in your eyewear or contact lenses. So they assume that the patient's always going to go with the managed vision care plan, which in fact, probably, I haven't done research on it, but when I looked at records, we don't see 100% capitulation over to the managed vision care plan, right? We see a pretty good split because it depends on the patient's benefits. I would tell you that if I was a patient and I learned that I had duplicative coverage and I was denied the choice of which coverage I wanted to use by a physician, and that decision was made for me, I probably would never return to that physician, right? I would have a serious issue with them not allowing me to have the freedom of choice over my own healthcare. And I think that could get into other issues that we could discuss at some point in time. But, I think that the assertion that people are going to always choose managed vision care is what drives the behavior to take away the choice from the patient.
Yeah, and I think the effort is to try to simplify the practice, like to simplify the care delivery and the reason that a lot of people don't want to have that conversation is, one, they're uncomfortable with it. They haven't practiced it enough, probably. Two, if they have, it adds complexity and nuance that they'd have to address in some sort of build around that disease state, right? They're going to have to know, okay, well, if a patient decides this path or that path, how is it going to impact my ability to care for them? But those are things that, again, if you can manufacture largely the 90 to 95% of those kind of pathways, then you just need to take care of the patient, and the amount of times that this kind of stuff comes up is rare, right?
Yeah.
And
Well,
then
I kind
the
of laugh
uncertainty is rare.
I kind of laugh when you say, take our 3% or 5% that only have, diabetes, no concomitant, issues or anything else. Here we go again, making decisions based upon the minority, right?
Right,
I mean,
right.
I guess I tend to look at this maybe from a different perspective. Is just, I get so frustrated because I want people to think about the patient and what our true role is, right? We are the entry point for many of these individuals into the healthcare system. And we've been given this wonderful gift to be able to have a preventive care benefit by Medicare that was adopted rapidly by other third-party medical carriers across the country. And yet here we are at the practice level, still trying to dig it out between a managed vision care exam that we don't want to do, but we still agree to do it, right? Because we quote unquote need the warm bodies in our chairs. And, I think that's the thing, right? Because I think if you think of the argument of, I don't have a Crohn's disease eye exam. I don't have a hypercholesteremic eye exam. I don't have a hypertensive eye exam. I still have just a comprehensive eye exam. And that's exactly what the diabetic benefit was if we go back to the genesis of the 2008 ruling. Medicare would have clearly said, look, bill us with the 99,000 code, right?
Yep.
But it's not, right? Because it's a preventive benefit. So the patient doesn't have the disease state yet that they would invoke to do those 99,000 codes. So we went to a comprehensive eye exam code to be able to provide that preventive benefit. And I just think that maybe people don't know the history on that. Maybe, they don't understand the genesis of how we got to where we are today.
Well, I think that's really helpful. And so if I were going to apply this, kind of practically in my practice, and then, not every practice, and this is why we did develop COS, and we'll talk a little bit more about that, I think, at the end, but
yeah,
is that not every practice functions like my practice. But if I step back and say, listen, I just want to take care of the patient. I want to do what's in their best interest every single time. And I don't want to have to worry about, who's going to pay for what, right? I'm going to build, I do worry about it, but I'm going to build a system around this so that I just get to deliver care to the patient. I look at it and I say, okay, a comprehensive exam is very broad, but it can't be by nature, it can't be deep. And so if I try to pile everything that I'm supposed to do for any of the disease states that I might encounter during a comprehensive exam, it's unrealistic that I'll be able to manage any one of those things sufficiently based on clinical practice guidelines or preferred practice patterns that I will likely have to follow up with that patient at some other interval. And so because of that, I look at it and say, if I take that approach and I do my job and I think, okay, this patient has diabetes, that's the primary reason they're here today, and they need a comprehensive exam. At that point, my brain doesn't care anymore because we built systems in our office so that I don't care who pays for it. Honestly, I don't care if I do. I'm an optometrist. I don't care if I get paid $55 or $155 for that exam. I do, but if I'm doing my job, it matters very little because I know that patient who has diabetes is at greater risk for cranial nerve palsies. They're at greater risk for neurotrophic keratitis. They're at greater risk for meibomian gland dysfunction. They're at greater risk for glaucoma. They're at greater risk for AMD, et cetera, et cetera, et cetera. And the likelihood that I'm able to, and so if I'm filtering my brain in my clinical examination for identifying the findings or the symptoms that will uncover those other disease states, well, I've done my job for the patient. And if I'm communicating with them well and addressing those things at a separate follow-up, then I've identified the patient's risk factors and I've driven value for the patient primarily, but the value for the practice will come. Where else
key
should I be
difference,
thinking
Chris,
if we're going to wrap this up?
that
Well, the key
I'll just say
difference
that
is,
the key difference between that approach and what's happening out in the field is monumental. And here's what it is. You're not thinking of the eye exam as an event, as an end all be all, right? You're looking at it as part of the process of providing longitudinal care to that patient, which is exactly what Medicare wanted you to do when they came out with that rule. So you
interesting.
built in those systems to provide longitudinal care to really give that patient a safety net. Most people who are trying to short term this and maximize their reimbursement and convert to medical and do it is because, number one, they don't want to have the conversation because they don't know how to answer all the questions that the patient may have. They don't want to introduce another variable. And they're looking at it as, I'm not going to see that patient anyways for another year and a half, 28 months, whatever the hell it is between eye exam intervals. So I better capture everything I possibly can today. And that's not what you're doing. What you're doing is saying, I have a systematic approach to following this disease state longitudinally, because that patient is going to be my patient for a number of years. And I understand the risk factor that comes with this systemic disease, even if they're not exhibiting any of those characteristics today. I am still the primary caregiver that's going to be working with this over time. And I have an obligation to not only manage and early detect their diabetic retinopathy, but every other type of systemic disease or local things that they may manifest because of the greater risk that comes with diabetes as a disease state. So it's a fundamentally different approach. I can look at it as an event. I better get everything I can out of it. Or, hey, I don't really worry about it because my job is to provide care for this patient for the next 30 years.
I love the summary. So here's what I want to do. I think to kind of close this up, I think that's such the reality of kind of the back and forth of slightly different approaches, but we've landed in the exact same place, John, is that I love the idea that you've talked about this as an event. If we view the comprehensive exam as an event rather than a process or an entry point to a process of care, then we will always have the weirdness that occurs and the discomfort that occurs that people will get caught up in. But if we can actually structure our approach, which is what we're trained to do, like if you look at all of the, look at the schools and we look at the, we look at ARBO and we look at all of our NBEO, like we're trained, we always advocate that we are the primary care providers for the eye and visual system. And sometimes our behaviors, and again, I think it's all based of good. I think that we do these things because we're just trying to care for the patient, but we build these systems in place that just don't allow us to fully do it. So I think the bottom line is, if this is interesting to you, if you like the idea of building systems over time, that is what we built with Practice Performance Partners. If you're a PPP Pro member, you have access to what John has discussed within Comprehensive Optometry Simplified. You have to just build your system. If you want to reach out to us within that and have additional help, we'd love to work with you. John, thanks so much for coming on. We will see everybody
Chris,
next month. Appreciate it. Great job.
Look forward to it. Take care.
You too.